All right. Can I invite I to up a little bit more on the front? One or two? Yeah, okay. All right, so we're just waiting now.
Sure.
Know when it's okay. Thank you for this special seminar. It's not part of our regular weekly session, so I'm very grateful that Brian Pence is with us this morning to share some of his work that he's been doing, particularly in the area of integrating mental health within HIV care, although I know Brian will speak more generally as well initially. This not only has been working in this area in the developing world, mainly in Malawi and in Cameroon, and we'll be talking about that, but also had one of the largest studies of it in the US called SAM. Maybe at some point you might want to say a little bit about how your experience of working on integrated mental health HIV care in the US might have informed what you're doing in Malawi and Cameroon. So, an associate professor at UNC and also heads one of the 11 NIMH hubs, which are funding scaling up research in the area of mental health. And I think you will also be saying something about the work in Malawi that you just started a year ago as part of that hub. So welcome to our department, and we're looking forward to hearing about your work.
Thank you very much. Thank you, Vikram. So here, trying to decide if it was a little presumptuous of me to be lecturing on global mental health in front of Vikram Patel, who's defined much of this field, and many of you who also work in this field and have done so much. I just wanted to get a brief sense of who's in the room. So try just raising your hands if you're a faculty member here in the department, post graduates, partners from around. Fantastic, good. So a mix of folks. And how many people work in mental health? I was trying to be near the microphone, which is unfortunate because I like to wander. How many people work in mental health in one way or another? How many people work in HIV in one way or another? Okay, a bunch of other interests as well. So I'll start more broadly. I will talk a little bit about the intersection of mental health and HIV as we move through the talk, but to start, well, first, I don't have any conflicts of interest related to this talk. These are my funding sources and disclosures. I want to start by, I have the title of Advancing the Global Mental Health Agenda, so I wanted to start by just spending a little bit of time defining what the Global Mental Health Agenda is. So in a number in recent years of large funding initiatives focus on grand challenges in global mental health from the National Institute of Mental Health, Grand Challenges Canada, high profile within the UN, World Health Organization. So what is this global mental health agenda that these initiatives have been focused on? It's been from a couple of fairly big picture observations, the first being that mental health disorders pose a heavy death and disability burden worldwide. So this is a schematic of how disability-adjusted life years from the Global Burden of Disease Study are distributed between chronic diseases, infectious diseases, and see that mental health disorders represent a really important portion of overall disability-adjusted life years. This is true both in the high-income and in low- and middle-income countries, pretty much cross-culturally. And there's a good argument that that slice of the pie is pretty underestimated. This is a reanalysis of global burden of disease data published in Lancet Psychiatry a couple of years ago. That highlights in green a whole bunch of causes of disability-adjusted life years that are not attributed to mental health in the general calculation, but self-harm is categorized under injury, the vast majority of which are almost certainly suicides, completed suicides due to mental disorders. So the authors of this analysis suggested that while the Global Burden of Disease study suggests that mental health disorders, including substance use disorders, can be claimed to be responsible for about 7% of disability-adjusted life years, they approximately double that estimate with the corrections that they suggest. So this is true, as I said, across countries, and that the burden is particularly high if you look for the yellow, orange, and red in many of the lowest income and most resource-limited settings that we might think of, much of Africa, for example. And we also know that the availability of mental health specialists to respond to this high burden of disease is very limited. So here we have the number of mental health professionals overall per 1,000 population in lower middle, and high-income countries. So you see a little over 1 per 100,000. And just on psychiatrists, it's even less than that, and we can see it has not been changing over time. So limited supply of mental health professionals to respond to this very, very high burden of disease. We know that resource investment is not focused on mental health. So this is the distribution of overall development assistance for health worldwide. And we'll see where mental health is on the graph. I'll help you. It's here, 0.4% of total funding, according to this recent analysis. So we have a large need, a large gap, and very little funding attention being directed to address this need. So as a result, the World Health Organization, in its MHGAP, or Mental Health Gap Action Policy document that was published about a decade ago, pulled this together and said, we know that more than 75% of those with mental health and substance use disorders receive no treatment in the low and middle income countries. And so the MHGAP document really put forward a model for trying to start to deliver care in this context and address this burden. This is the question: how can we respond to this high burden of mental health disorders with this very limited resource workforce, very limited dollars that are being invested? And different threads to that overall undertaking, but one pretty substantial thread has focused on the question: how do we reduce the mental health treatment gap by training non-specialist health providers or even lay people to mental health interventions with fidelity and effectiveness? So the classical view is that a psychiatrist or a clinical psychologist with many years of training and tight supervision and adherence to fidelity of a very complicated protocol, that training is what's required in order to deliver cognitive behavioral therapy. So the question is break that model. And at this point, we know quite definitively that the answer is yes. So one of the earliest trials led by Vikram in India, the Manas trial, demonstrated that a step care intervention where lay counselors are trained to provide brief psych counseling with escalation to primary care providers prescribing antidepressants as needed was highly effective in addressing common mental disorders in the primary care population. And this has been followed by dozens of studies at this point, dozens of high-quality randomized controlled trials in a range of low and middle income settings, demonstrating that these lay health workers or community health workers or lay individuals can be, with appropriate training, supervision, relative low resource investment, can effectively deliver these brief evidence-based psychological interventions and achieve strong effects. Individuals such as grandmothers in Zimbabwe on the friendship bench, this is the intervention packaged by Dixon Shibanda's team in Zimbabwe, working with their village community members to deliver problem-solving therapy. So a recent review of this literature of over 2,000 randomized controlled trials said the review demonstrates that psychological treatments comprising a parsimonious set of common elements offered by a low-cost, readily available human resource have strong effects in reducing the burden of common mental disorders. So we have strong evidence base at this point, in order to say we have models that work in the lab, so to speak, in the carefully conducted randomized controlled trial. Which has really led a transition within the last few years to more of a focus, as in many other parts of health research, on implementation science. So we have an evidence-based, or even many packages of evidence-based interventions. How do we make them work in the real world? How do we take this high-quality research evidence and translate it so that it's having an effect in practice? So National Institute of Mental Health funded, as Vikram just mentioned, 11 global mental health hubs within the last 2 years, whose mission is to focus specifically on these implementation questions. So they're around the world. The colors on the map don't mean anything in particular, just I think designed to stand out a little bit. But four hubs working in ADEPT, PRISM, Essence, Aspire. I will say that this network has some of the best acronyms. The network that I've seen before. We have SHINE operating in the Middle East. The American group is the one that didn't really seem to make much of an effort on the acronym front, so I just made one up for them. Could have changed the A to an E somehow and gotten a smile. But also we have another 5 networks or hubs working in different parts of Africa, and the one I'll be speaking about a little bit later is SHARP, based in Malawi and in Tanzania. But 11 hubs as a network have an overall mission of both building capacity in mental health, implementation, science, and research to policy translation, as well as leading research themselves on implementation of evidence-based mental health interventions. So that's the background, kind of the overall background about a very brief overview of global mental health in general, and kind of where at least some of the current research focus is. I want to take a back in terms of my own entry into the field. So trained as an epidemiologist, of my initial work in the mental health and its overlap with HIV, focused on documenting burden, measuring associations, observational associations, as epidemiologists do. And Cameroon, about 10 years ago, is a place where, in partnership with several collaborators, started to turn our attention more to intervention, to what can we do to address mental health disorders. So Cameroon, as you can see, is located in sort of West Central Africa. This is the Day Hospital in Bamenda in North Cameroon, a facility that you will recognize its type from many other places in low-income countries. This is one of our key medical collaborators there. And the ADEPT study was an R34 pilot study funded by NIMH, targeted on this intersection between HIV and depression. So the population of interest was people living with HIV who also had depression. Prevention study. So the question was, our strategy, I should say, was to train a general practice nurse to screen for depression using a validated instrument, the PHQ-9, and to guide an existing HIV physician who had no prior mental health training. Neither of them had any prior mental health training in depressant management. And I'll take a little bit of a tangent here. Vikram referenced in his introduction my US-based work in the intersection between HIV and depression that this probably evolved out of. So the STAR-D trial in the United States, the sequence treatment alternatives to relieve depression, a trial early 2000s, the large trial of depression treatments in the US, possibly in the world, over 4,000 patients, focused on questions of comparing different antidepressants, but the way that they delivered the antidepressant regimens within this trial was done through a package which was developed for the trial called measurement-based care. And it really addressed the underlying issue in the global mental health gap that I highlighted earlier, which was how can we deliver protocol-important, high-quality antidepressant care without psychiatrists. In the STAR-D trial, about half the patients were followed by psychiatrists, but about half were followed in primary care. The trial developed this model of delivering, of supporting primary care physicians in prescribing and monitoring antidepressants in an algorithmic way. So the core components of what was called measurement-based care were once identify that someone has depression and you confirm that it's a medical diagnosis of major depressive disorder, you first prescribe an antidepressant. That's a huge gap in U.S. medical care. You schedule regular follow-up, and that's where the major gaps arise. So patients outside of psychiatric settings in the U.S. who are being treated for depression typically receive a starting antidepressant dose, and they've seen 6 months, a year, 2 years later, they might not be followed up. So the real key that this algorithm boiled down, how can we achieve better outcomes using non-specialists, was let's make sure we have regular follow-up. Let's use metrics to assess how patients are responding. In HIV, we measure viral loads. In hypertension, we measure blood pressure. In diabetes, we measure blood glucose. In depression, we can measure depressive severity to see whether treatment is working and can adjust treatment as needed until we achieve response, because antidepressant medications are not one-size-fits-all. So we need to monitor treatment response using a validated longitudinal tracking measure, and then adjust treatment as needed. If the patient has achieved full remission, great. If they've achieved partial remission, there's sort of a choice point. If they have not responded, we need to change the dose or consider changing the treatment plan altogether. And this is achieved, the quality of service delivery is really achieved through a supervision structure. So this generalist nurse has no training in mental health. The provider whom she is coaching has no training in mental health. Our structure was to hold weekly supervision calls with the nurse to review the case registry, talk about the patient that had come through, any questions that had arisen, was the protocol, were treatment plans following the protocol or not, if they were divergent, why, what feedback could she take back to the physician and to kind of inform care moving forward. And the target really being remission, based on a measure on this validated scale. So full resolution of depressive symptoms, not just feeling better, but getting to remission. And when, for those of you who work in HIV, the correlation there is, or the parallel there is, we don't just want people's viral loads to decrease, we want them to be undetectable. They're detectable, they're not infectious. So if we achieve remission of the depression, we've resolved the underlying medical condition. So a pilot study, this is not powered or even designed to really look at effectiveness or efficacy questions. This study was a pilot focusing on feasibility, acceptability, fidelity measures. So what we found was that we were to identify patients. So there was a screening assessment, and then the physician actually completed or followed a little checklist of their own to confirm that this was a current major depressive disorder. So 100% of those 55 identified patients were started on amitriptyline, which is the one antidepressant which was regularly available in the formulary at that time in Cameroon, which is really very similar to many in Africa that I'm aware of. There's typically a tricyclic available, but typically not SSRIs. That's starting to change a little bit. We actually had 98% follow-up of patients coming to their 4, 8, and 12-week appointments. So patients did return for their follow-up appointments. They were reassessed. And the provider showed 95% fidelity to our dosing algorithm. So depending on where patients were in their severity score at the return appointment, the provider's decision was concordant with what the algorithm recommended in 95% of those cases. There were minimal side effects experienced. And a piece that I'll highlight in a few slides, but that is worth mentioning here, is that there were baseline a number of patients reported either passive or active suicidal thoughts, and so we had a protocol around what do you do, how do you triage, assess what's needed, and respond appropriately clinically. So these were the main outcomes. The trial wasn't designed to look at effectiveness or efficacy outcomes, but of these 55 patients, there's a really dramatic depression treatment response. So the median PHQ-9 score was a 13 at baseline. So red of 10 or above on the PHQ-9 is the range of probable depressive disorder, moderate to severe symptoms. Yellow, which is 5 to 9, is the range of mild depressive symptoms, and then green of 4 or below is the range of remission of symptoms. So since went from a median of 13 to 6 to 2 of these 3 months of follow-up, and 87% had achieved full remission of their symptoms by 12 weeks. So really dramatic improvement. And this shows the distribution of suicidal thinking. So none being this lightest box, passive thoughts, active low-risk thoughts, and active moderate to high-risk thoughts. So you can see a pretty high burden of suicidal thinking at baseline, the vast majority of which resolved very rapidly. So a single-arm trial, we don't actually have a comparison group here. This is an open-label trial, so can't really claims about efficacy or effectiveness, but this could just be regression to the mean, right? Maybe just catching people when they happen to be high and they're responding, they get better because that's how statistics work. But this is a suggestion, certainly, of a pretty important clinical improvement in these patients. So what we took away from this work in Cameroon were certainly antidepressant treatment was acceptable and feasible, and one provider, whom we were financially supporting, was from one dedicated nurse who was a research staff member and whose time, therefore, really were able to direct, was able to follow this algorithm with high fidelity. These patients showed rapid and dramatic improvements. And I didn't present data on HIV treatment indicators, but those actually all also improved. So adherence improved, the proportion with suppressed viral load improved over those 12 weeks. So we've been thinking about those lessons from that study as we have been building up some work in Malawi over the past several years. So I'm going to talk a couple of projects that we have currently ongoing in Malawi. Malawi is comparable to Cameroon in size, about 18 million people. Cameroon, a decade ago, it currently has 3 psychiatrists, two of whom just graduated from medical school. So again, we have sort of this overwhelming. This is about more than a factor of 10 worse than the global statistics that I showed you for low-income countries many slides ago, in terms of the ratio of general population to psychiatrists. We have a range of other individuals with some mental health training, but overall still a pretty large gap. So the first project I'll speak about is called the SOAR-Malawi Mental Health Project. So SOAR is an overall funding portfolio that USAID has awarded to the Population Council with a consortium of partners. It's some very large number of dollars. It's supporting dozens of HIV operations research projects around the world. And part of that funding was earmarked for a project focused specifically on the question of whether treating mental health among people living with HIV will improve HIV treatment outcomes. So overall, I'll speak to this in a little bit, but the overall really focusing theme of HIV treatment survey and research right now is get as many people as possible on treatment, on sustained long-term treatments, and with suppressed HIV viral load. And some of the big gaps that we see are patients falling out of care, patients not adhering to medications, therefore patients not responding to treatment. That many people, and I've done some of this research as well, has these strong and consistent associations between depression and outcomes along this HIV treatment continuum. And so the question is, well, if we were to integrate psychological support, mental health treatment into HIV care, will we see better HIV outcomes? Should this be informing PEPFAR funding policies and principles? Our objective with this pilot study, or not a pilot study, we'll call it a demonstration project, was to integrate depression screening and treatment into HIV primary care. I didn't want to parachute in some sort of load that couldn't be replicated because that would not really inform PEPFAR policy more broadly. We wanted to see what could actually integrate within existing care. And when we integrate it, what impact will that program of mental health service delivery have on the mental health and HIV outcomes? So our primary outcomes are depression, remission, HIV care, and HIV viral load suppression. So this project is focused in 2 primary healthcare clinics in Lilongwe. So these are places, again, many people will be familiar with their peers from many other places in the low-income communities. These are deliver HIV care, maternal and well child care, under 5 care, prenatal care, outpatient, essentially infectious disease clinics, all under one roof, depending on the day of the week, with providers that rotate across services. A provider might be in the ART service one day, in prenatal services the next day, in under 5 the next day, outpatient the next day. Providers rotate between clinics. And so really, in order to think about if we're focusing on the HIV population in this project, how mental health care within HIV care, we must work with one dedicated, committed provider, as we did in the Cameroon project. We really need to train all of these providers. All providers need to know how to manage mental health if they are rotating through the ART clinic on a weekly basis. So some different issues from the Cameroon project. Our patient design is a staggered pre-post. We didn't have funds to do a multi-site clinic randomized controlled trial, so we had 2 clinics where we had a pre-period, and then we integrate the program, and that happens at different time points, so gives some protection around just confounding by history. And I want to talk a little bit about what is that depression treatment program that we focused on integrating. And in designing this program, we were guided by the way in which guidelines have really suggested thinking about integrating depression treatment care through the MHGAP and other documents. So there are a few components that we need. So the first component that we need is universal depression screening. We know is that a lot of depression goes unrecognized, certainly clinically unrecognized. We then clinical assessment to confirm that the screening is accurate. Most screening tools, they tend to be highly sensitive, not as specific. We need a treatment plan. We need a follow-up plan. So those are different components we had to think about integrating. So we use standardized tools for screening and assessment. So the PHQ-2 is the first 2 items in PHQ-9, and it works very well as a first-line screener. So it's a good thing to give everyone initially, and a smaller subset can get a more detailed assessment with the PHQ-9. So 0, that's follow-up. But if you get more than a 0 on this PHQ-2, the 2 items, onto the PHQ-9 assessments. And maybe you end up in the 0 to 4 range, deemed not depressed, and no treatment is indicated. Maybe you end up in that middle, mild depressive severity range. So that's a range where counseling is probably most appropriate. So our focus in this project was delivering a problem-solving therapy protocol of psychological counseling. This is the Friendship Bench program that I alluded to earlier a few slides ago, developed by Dixon Shabanda's group in Zimbabwe. If you're in the 10 or above range, the indication is to start antidepressants prescription. This, again, is either amitriptyline or, in this case, fluoxetine are the 2 treatments that are available. But with the clinician having some discretion, modifying that plan if needed, if it's clinically appropriate in their judgment. And the critical piece is reevaluation at monthly visits. So HIV patients return monthly anyway to get their antiretroviral treatment refills. And so let's layer in a depressive severity reassessment at those time points so the plan can be reevaluated and adjusted as needed. So the components deliver these components. How it's actually going to work within a primary care clinic in Malawi. Who's going to do each of these things? So in this particular case, we ended up integrating the PHQ-2, the post-test counseling that's delivered by the HIV testing counselor. So this person already does a variety of things with the patient when they test positive before walking them to the ART clinic. So we PHQ-2 that. And if they get more than 0, the patient is handed a PHQ-9. Almost everyone is not literate in these clinic patient populations. So they're handed a PHQ-9 to take the exam room with them when they meet with the clinical officer or the nurse who's providing them their antiretroviral prescription. So the key provider is the one who administers the PHQ-9 and then makes a determination of where this patient falls in our algorithm. And if they go into the counseling arm, we have trained the lay health worker, a few members of the lay health worker cadre at these clinics, who in Malawi are called health surveillance assistants, to deliver the friendship bench training. So Dixon Jabanda's team came from Zimbabwe to Malawi and trained a group of Malawian trainers. We've now delivered 3 trainings to date for certain number of health surveillance assistants to be the counselors. They do either problem-solving therapy with the counselor, or they work with the provider to prescribe an antidepressant, and the provider is in charge of the assessments, the reassessment at clinic follow-ups. When the provider is not going to be the same provider, as I said, because of the very frequent rotation of staff, we can't depend on patient A seeing provider B at every visit. So it needs to be a system where provider D can pick up the packet and understand the patient's history and move forward. So the system it's still in process, so we don't have outcome, kind of treatment outcome results to share at this point, but we do have some process results. This is sort of a Cascade figure, and I'll talk about Cascades again in a few minutes, but if we look at the total number of new antiretroviral treatment patients, which was about 1,400 or so, who had clinic at the point that we kind of did this data pull, between all of those patients. So for the most part we did. We got about 90% of the patients did complete the PHQ-2 screening. This is from inception to date, so it took some troubleshooting, tweaking, but reliably people get screened. Of those who get screened, a little less than half screen positive. The one thing that means is that there are a fair number of folks who already triaged out of further assessment, which is helpful. So with 2 questions, we've been able to narrow our focus quite a bit. So 35% that were positive on the PHQ-2. Our next step is that they all should get a PHQ-9. And the process question, and for the most part they do. Not quite everyone, but about 90% do end up getting a PHQ-9. This is, again, something that took a fair amount of troubleshooting at the beginning, but mostly now the system works. They get a PHQ-9. Of those who complete the PHQ-9, about end up with at least mild depressive symptoms, either in the yellow or red zone, and about 15% end up in the red zone, so 10 or above. So we have an overall prevalence of depressive symptoms of between 20 and 25% in the population. So thinking about big picture successes and challenges so to date with this project, with qualitative interviews that we've done both at the outset and then about halfway through, there is very high recognition, both among providers and patients, of psychological struggles. That is termed depression specifically. Patients do say, yes, this is a real challenge for us or for my patients. This is something that really could use more support with. Interestingly, providers and patients really seem to think about depression in the context of their HIV diagnosis. I was diagnosed with HIV, that's very stressful. I'm now with HIV lifelong. This comes with all sorts of disclosure, concern about my husband, family, my community, rejecting me. So the concept of depression is really tied up with the concept of the HIV rather than sort of its own medical condition that merits its own treatment plan. But still, definitely recognition of need and appropriate treatment. Some indicators that, as I highlighted in the last slide, are pretty positive. State suicidality triage completed 97% of the time. And almost one starts something. So about 90% of the patients with those depressive symptoms have started the Friendship Bench program, and about 95% in the 10 or above have started an antidepressant. There have, as I said, all the providers. It has been challenging to reach all the providers, make sure that everyone's trained and equipped. This is a logistic issue, partially this is honestly an engagement issue. Action at follow-up appointments. So again, many of you will be familiar with, we don't have great longitudinal monitoring systems in most health systems throughout the world, and Malawi is no exception. So the exception, as Vikram and I were talking about earlier, really is HIV treatment programs that have been quite successful in recent years in setting up systems that have ensured follow-up over time. And in most also is true. There's an electronic medical record system that serves a few functions, but one of them is HIV, and everyone who comes in gets a barcode on their ADEPT MasterCard for every appointment that they show up at. Their medication, dose, etc. So we really tried to off of that system. There's a paper MasterCard, so we developed a paper mental health MasterCard that could be filed with the ART MasterCard. It should be pulled out at the same time. So a way of tracking the PHQ-9 score over time and the treatment plan over time. So it's been challenging to implement. The question, do we work within the system or do we create our own siloed system that we could have more control of, but that would, really have fewer benefits in terms of, the picture of helping the health system evolve. It has been challenging, honestly, to keep providers engaged in ongoing supervision and refreshers. So, in terms of schedules, people rotating into and out of the clinic, repeating trainings, etc. So we want to make sure that providers understand the algorithm well enough to be providing high-quality care. We do that primarily through these supervisions and refreshers, and logistically that's been challenging to deliver. This overall engagement is a something that we talk about on our calls. How we can continually support leadership engagement. Arlie, from this project, kind of building a little bit from what I discussed about Cameroon, is that so we really focused in these clinics on integrating to existing clinical care, not putting in new staff, new counselors, but it's really relied a lot on our paid coordinator, who does a lot of running around. The matron, meeting with the director, meeting with the providers, meeting with the counselors, why medications, where are the MasterCards? So there's a lot of chasing that is involved. Honestly, wouldn't happen if our person weren't there. So thinking about how do we make that handoff, this is really more owned locally and sustainable locally at this clinic as we transition out of the project. But this person has been successful in integrating screening, integrating treatment, integrating the paper system. So it can be done. With dedication, it can be done. Certainly, this large number of providers spend a period of implementation rather than research, so we're not paying these providers to be doing this depression care. It's a mandate from the ministry that care is changing, and this is now what they're doing in addition to ART. That, as you imagine, has met with mixed receptions. So, without financial incentives, how do we ensure engagement? And have this systems issue, which continues to pose a big problem, the chronic disease management. So just briefly to give you an overview of SHARP. So SHARP, as you might recall, is one of these 11 implementation hubs funded by NIMH within the last year or two. So we are working in Malawi and Tanzania. So our objective is to expand mental health treatment through high-quality implementation research, through developing capacity in research and implementation, and through really building dialogue and communication between researchers and governmental partners. So the research component is focusing on integrating the same depression care package into communicable diseases clinics in district hospitals in 10 different districts in Malawi. So clinic randomized RCT focus on 2 different implementation packages. So whether we are providing sort of one level of support or a more intensive level of support to the clinics to support them in integrating this patient care package into their normal workflow. So we compare the fidelity implementation, the patient outcomes, and the cost between these different strategies to implementing different care on a larger scale. This is from the district health officers that we had from those 10 districts. We had to prove the concept and get their feedback. And from the capacity building side, a combination of skills-focused short courses in implementation science research, based mental health interventions, targeted both to researchers and policymakers, and with this goal of really building those communication bridges. So we have pilot grants that we award to researcher policymaker teams that want to do small implementation science projects around mental health activities. This is a pick from the first round of skills courses that were delivered over the summer. So what comes from this overall initiative are evidence on the most effective and cost-effective implementation strategies for scaling up depression care within existing health settings in the Malawian health system, as well as this expansion of capacity to conduct and translate this research into policy in Malawi and Tanzania. Through a bunch of projects and sort of current activities, I wanted to take a little bit of a step back, and I'm transitioning momentarily back to the HIV world. So you who work in HIV have seen almost certainly this figure or its derivatives. This is not actually the first, but the formative HIV treatment cascade that was published in 2011. It's a different way of thinking about the HIV treatment challenge. So this figure in the U.S., some people at that time estimated to be living with HIV, then were diagnosed. So these are another HIV positive. Are in HIV care. So these are care. Retained in care versus having been lost to care. Need therapy isn't really applicable anymore because guidelines are now that everyone should start ART. Of those who needed it, some fraction don't take it, and of those who take it, not everyone achieves viral detection. So it's a way of thinking at a global level about the fact that at the time, about 20% or less of the people living with HIV were virally suppressed. It's been amazing to see in the last 7 years how this essentially one figure has completely transformed the service, provision, and research agenda. So the world essentially has rallied around a goal, and the goal is that 90% of people living with HIV need to know their diagnosis. None of those diagnosed need to be on ART, and 9% of those on ART need to be virally suppressed. And the reason why those goals have been articulated is because modeling has pretty convincingly argued that if we were able to achieve these goals, the HIV epidemic would end. So pieces that have gone into making this argument possible, the second one being the very convincing evidence now that those who are virally suppressed are not infectious. And so if we were able to achieve this, there would be a dramatic reduction of infections such that the epidemic number rho would go below 1 and the epidemic would die out. And so now all of these clear calls that we have to achieve 90-90-90, and we will end the AIDS epidemic. So this is some food for thought. All right, so the food for thought really is, well, interesting. Depression treatment cascade might look like. This is on data from the U.S. based on sort of a systematic review, but we did a follow-up paper in which we did 8 actual clinics and kind of walked them through the cascade, got very similar numbers. So there's pretty good evidence that if you think about just this as all the people living with depression who might be passing through a healthcare system. So this review is focused on people living with HIV, but you get pretty much the same numbers if you think about primary care populations or other medical populations. A little bit under half are clinically recognized. And recognized about half start any sort of depression treatment. And a little bit earlier, most depression treatment that's provided in primary care or HIV care is here's a prescription, see you in 6 months. So a pretty small proportion of those starting any sort of treatments are what we might call effective treatments, where receiving an evidence-based psychological counseling protocol or are receiving an antidepressant prescription that's being managed to remission. If it's done, then remission is very likely. See that this fall off, if we were feeling badly about the HIV treatment cascade, you know, a much more dismal picture, and this is in the U.S., right? I would say that the picture in the Malawian primary care system looks like this. Right? So no one is recognized clinically. No one recognized clinically is started on treatment. So we know that outcomes are just abysmal, right? So the question is, kind of the thought experiment is, what would it take? What would it take to achieve 90-90-90 in depression care? What would it take to reach 90% identification of those presenting to primary care, HIV care, other points in the health system with mild to moderate to severe depressive symptoms? What would it take 90% of those individuals to be getting some level of treatment? What would it take for 90% of those receiving treatment to actually achieve remission because receiving high-quality treatment? So let's step back and think about, well, are there lessons we can learn here from HIV? What made the dramatic expansion of HIV treatments within the last 10 years of the low and middle income countries? What has made that possible? And these are not an exhaustive list, but these are a few things that come to mind. Organizing force has been the very clear evidence of payoff of the impact of universal HIV treatment. This consensus, the scientific consensus, the policy consensus that we can end the HIV epidemic. It's level goals, 90-90-90. And so, as a payoff, goals. Third critical element has been measurement and feedback. Sarah Burke speaks, the U.S. ambassador for the Office on Global AIDS. So PEPFAR, that administers U.S. aid for HIV treatment, is very focused on measurement down to the granular level, country, district, health, to clinic. What is your clinic's success rate in getting people on treatment, to a suppressed viral load? How to help us allocate resources to those that are not yet meeting goals? How do you provide feedback on a regular basis, weekly, daily, to make sure that resources is focused? Another key element, certainly in Malawi, and I think this is true in many other health systems, has been the generalization of the responsibility for HIV care. So as I said, Malawi providers rotate through every service in most clinics. And all providers are HIV providers. They all rotate through the ART clinic. If you want to get a job anywhere in the Malawi health system, you do it if your HIV training is not current. You can't, because you won't be able to provide services in the ART clinic. So there's a bottleneck, or there's a checkpoint which ensures that providers are up to date on their HIV training. And focus and leadership from multiple levels: policy, funders, scientific community. So what I need is, how do these lessons translate to depression care? So it's the evidence of payoff. Those of us who work in this field could make passionate arguments about the evidence for payoff, about improved life, improved employability, reduced burden of other illnesses, better engagement and care for other illnesses. But those images, as articulately as they have been made, that have not led to the same level of focus, right? What are quantifiable goals that we could rally around, and how can we measure success and provide feedback at a newer level towards the success in meeting those goals? Having all providers, mental health providers, as kind of this idea of task-shifting mental health, or task-sharing mental health interventions, and how we maximize focus and leadership to help achieve these goals. Really, with a vision, our goal is to say, of mental illnesses being broadly recognized by those affecting their communities and providers as a treatable health condition and a personal weakness or a fact of life. So, And just a few thoughts to share with you. And of course, none of this work is possible without large teams in many places. Our team, the original project in Cameroon, is from our second Friendship Bench training. This is our guy who makes everything happen at all of the clinics. Dixon and his colleague Ruth delivering the training of trainers in the Friendship Bench. Here, this is a meeting, one of our team meetings, the SOAR-Mental Health meeting with the clinic leadership and the district health officers here, and then our team at some adventure or other. And of course, funding from National Institute of Mental Health, USA, PEPFAR, and Project SOAR Population Council. So thank you for your attention. It's been a privilege to speak to you, and I'd be very happy to take any questions.
Thank you, Brian. So I have some time for questions. I thought I'd just kick off. So thank you for this terrific talk, and also it gives us a sense of the journey that you've taken, moving from HIV to depression from the US to sub-Saharan Africa. Some of the observations I thought really chimed with my own experiences. In particular, I thought the point you made about the person who is going to hold the baby in the clinic, I think is quite an important one. For very long in our field, we've often thought of essentially trying to integrate to the extent where existing human service providers were essentially going to do what we're doing plus the mental care. And my experience exactly coincides with yours, that unless there's somebody who is in the facility who will actually be responsible for something other than ensuring that the management of depression in this case was integrated in the work of everyone in the facility happen. And this does mean that an additional investment has to be made, because the Indian agenda has often assumed that there is no additional human resource investment. But it sounds to me from what you're saying, and perhaps you might want to also respond to that, we must accept that without additional human resource investment, you'll be able to scale up. The literature really tells us, I think, for 30 or 40 years, that the idea of just training primary care providers is in itself an insufficient intervention. In fact, all the literature says that after training, within 6 months or a year, everything's back to where it was before training. And the only way you can sustain those gains after training is by having someone monitoring, supporting within the clinic. This is what you alluded to, and is something which I also have heard about from others working in sub-Saharan Africa, is opportunity that HIV has offered in a paradoxical way. Paradoxical because it's such a health condition, but in re-engineering healthcare systems to approach HIV care, de facto we have a chronic disease management platform in at least those countries in which there is a well-developed HIV care system. I thought that the idea that you suggested that this chronic disease platform that developed isn't HIV specific. The only thing that's HIV specific really is the specific diagnostic and clinical interventions, but the actual system level changes, for example, a long-term outlook, monitoring, proactive screening, all of these actually are applicable across all chronic diseases, including, of course, mental health conditions. And so, in many ways, for those of us who find ourselves working in countries where HIV is a major health issue and where governments have responded in a way that many African governments have, I think it's a unique opportunity for us to actually look at the lessons from that HIV platform for extending to other healthcare, other health issues that are also chronic. Questions for you, and maybe we'll take some more questions, and perhaps you could then answer a batch.
Sure.
So the first question was whether as we go universal with ARTs, in going forward, that's going to be the goal, and the 90% of everyone who is infected will be on ARTs. Do you see that the role of mental health will actually grow? Because potentially from a smaller fraction of individuals who are getting ARTs, because one of the interest in mental health has been in mental health being one of the predictors of poor treatment adherence. So do you see a change in the importance that is given to mental health within HIV programs? Second question is, Alan, you and us about disease model in depression. I think there is a problem when we, as we always do, and myself included, treat depression as if it's a binary condition. With AD, it's very easy to do that because either you have the infection or you don't. Yeah, they'll be neatly divided into these two groups. I'm not sure that this disease binary model applies to almost any mental health condition. It really lies on a spectrum, and therefore does require a more complex staged model of thinking about mental health problems. And you certainly allude to that. But I want to hear a little bit more about the idea that those 1999 translates from what is effectively a binary disease with a biological cause to something that can imperceptibly merge with misery at the end, and with extreme, profound disability at the other end. The spectrum is so vast. How do you take these, I think, quite simple metrics for simple conditions? HIV is not simple, but I think it's a lot simpler than like depression, which I think is just far more complex to conceptualize. And I just want to say what remarkable quality outcomes you had. And I think most U.S. practices couldn't be 95% treatment complete for anything. So that's remarkable. I wonder, was there something about the pride that you can learn from that can be re-exported back here? How do you achieve these sorts of treatment completion rates in Malawi? I mean, I think most high-income countries would be nice to see them. What are the lessons you get from the provider? Let's take a few questions, and then we can, introduce yourself as well. So we've got, sorry, I couldn't see the hand at the back. So maybe we'll start with you, and then yourself, and then yourself.
I absolutely think say universal and actual population is HIV. Right. But how do you take into account the future that you're going to look at population and look at population? Second question is according to the implementation of your process of implementation, how do you, for example, implement OBGYN? Exactly. How do you look at the question exactly for the day? How do you look for this program and
I understood your first question. So you're commenting on the universal screening discussion,
yes.
But I was focusing only on ART patients. So yeah, exactly. So how can we think about universal more broadly? Okay, great. All right.
So it's one along the lines of victims. What happens to the people who are triaged out after screening? Do they receive psychiatric or psychological services, or is the program based only on those who seem to be? Second, and this is probably my ignorance, I'm not a physician, but do you think the specific barriers in the sub-Saharan African setting that we're working in are to the integration of mental health care as a kind of adjunctive therapy for diseases like HIV, where obviously psychiatric disturbances are going to significantly affect adherence, kinds of issues that are crucial to the 90-90-90 target. Why has it been difficult to look at mental health care in the same way that one might look at other kinds of things?
Chance, because it's quite a bunch of questions, and then we'll take the next round of questions.
Perfect. Good. Okay. Yeah, thank you for these questions. So I'll respond first to a comment you made, which before your questions, but this question, do we need additional resources? And I would say, I think, yes, certainly our lessons so far from these projects have been, you do need a person. And I think the key transition in thinking, I believe, have been coming from a place of we need a psychiatrist to deliver mental health care. An addition that is possible is, no, we need someone who cares about mental health care to be that chaser to system that now know can be delivered without the specialist, but you need a chaser or a coordinator, or someone who's going to play that role, for sure. I think that seems like a pretty good lesson. but those are in bigger supply than psychiatrists. So you asked about whether the role of mental health in the 90-90-90 goals for HIV, and I think this is actually a really critical question. So I would certainly argue that as HIV treatment expands, mental health supports are going to be even more important, because you are moving from treating the people at death's door who are experiencing dramatic recoveries from psychotropical therapy and are highly motivated to maintain that treatment, to now treat a large pool of people who are not sick, feel sick, but have a positive blood test. And long-term engagement in ART, lifelong adherence to a daily pill regimen is going to be cognitive dissonance to begin with. Also is going to run into barriers to the extent that mental health issues are present. So I think that for the 90-90 goals to be achieved, there's going to have to be attention to the mental health issues that coexist with and along with HIV infection. You had area consideration of depression versus it being on a spectrum. Certainly, absolutely agree with the model, conceptual model, thinking about depression. And this is the reason for thinking about step models, as we talked about in a very simplistic way. You have maybe those who think are, doing support, those who need a psychological support intervention, those who are in the region they need medication. So that's a 3-level as opposed to 2-level. Again, a little bit rough, but a little bit more fun. I think in a transition that's important is think not only about the illness, but about health promotion. I mean, certainly from Malawi, a lot of the individuals recognize the challenges that people go through in daily life, did not recognize depression as an illness, or some needed its own medical management as well. These are people going. So in fact, many of the people who go to the friendship bench and are counseled by the friendship bench counsel have no idea. They would not call that depression counseling. We know from our qualitative interviews, they don't perceive themselves as being in depression treatment. So we don't want to label on these individuals that is different with how they view themselves. But does that mean the program can't move forward, or should we be branding it as a health promotion program, or a, as you titled your program, the healthy living, healthy activity, thinking healthy, thinking positive, turn it to a positive. This is something everyone can benefit from, as opposed to you have a mental disorder and there be treatment. So I think that's this issue of where people fall on the spectrum and how clinically we maybe refine our response is an important one. You asked how we achieve 95% fidelity in that trial, and there are parts to that question. One is that so many patients responded so quickly to amitriptyline that few dose adjustments were needed. It's an easy pass on fidelity because actually passive behavior was what the algorithm indicated. But in the cases where patients didn't respond and needed dose adjustments, for the most part, they did happen, which is what really set a particular experience apart from most, as you said, most primary care and other settings. And it was one provider who was willing to listen to a nurse whom we were closely supervising, and a tool that the two of them, used together. So it was a lot about the individuals and the relationships, as well as confidence that the provider in the support that she was receiving. Slam Dunk trial that you referenced in your introduction, which was a trial of integrating measurement-based care into HIV care in 4 different clinics in the U.S. We had bigger challenges with fidelity. Even we had the same person that role as the nurse, we called our depression care manager, who was working directly with all of the HIV providers. There were bigger divergences, largely because many of the providers disagreed with our assessment on some of their patients, which they had their clinical picture. Like, this is someone who really needs substance abuse treatment. They don't need an antidepressant. Because there's just a lot of clinical inertia. Prescriptions, dose adjustments, just not making it the system. So if you're able to do something something very small in a very small and focused setting, and that's a real challenge now in Malawi in the SOAR studies is thinking about how do we scale up the success of what I think was very largely built on individual relationships. So asked about universal screening, and so universal screening is the essential principle of scale healthcare. This study, the SOAR-Mental health study, had as its population of interest people starting with people newly diagnosed with HIV, because interest of the funder. But certainly, and this will tie into to Aaron's question, certainly we're not interested in those starting ART, but those in established ART care. And so ideally patients will be receiving depression screening at regular intervals, maybe every 6 months, or if they're in established care, they get a screen and then moving forward they get rescreened, so that we're able to pick up new depressive symptoms that arise and we're able to respond even to someone who did have depressive symptoms earlier. Certainly thinking about how do we take these into other clinical services like PD, like OB/GYN, antenatal care, well child care. There's certainly different considerations. Child and adolescent mental health issues versus adult mental health issues have some different for sure. But I think the general principle of whatever the population is, starting with universal screening is a key part. So yes, when you're talking about patients who are treated out, so exactly, if someone has symptoms currently, we would not be indicated for depression intervention if they arise. So we want to get that individual sort of on the radar screen we want to have a system of routine screening at regular intervals so we could identify patients with newly arising psych stress that we could respond to. But we're thinking about how does mental health treatment relate to HIV care and the psychosocial support that's been a key part of HIV rollout. One observation we've had from our SOAR mental health study is that, as I said, we did this kind of the pre-post phase, and the phase was being an identification and referrals to existing care. We did make sure that there was safety net care at each site, education of providers, and so we tracked what happened to patients, and everyone received something. So we have a box on the master card, what happened, medication, counseling, everyone who was identified as depressed got counseling. But when we done our training, friendship bench counseling, so when we talked to the providers about what does that mean, you seems to have meant, well, I talked to them like I talked to them. I did my standard ART counseling. I'm going to take your medications. You're going to need to get support from your family. See you next month. And so there certainly are models for delivering psychosocial support within HIV. In fact, depending on the country, some countries you can't start ART for a month because you have to have gone to the psychosocial counseling sessions beforehand to ensure that you're ready to start ART, your support system's in place, you understand what you're doing. That model's changing a little bit, but there is this from pre-counseling to post-test counseling to ART counseling, there's a kind of a model of addressing psychosocial issues. But I think interested in addressing the mental health burden, we need to ensure we're not only doing it from the context of social support. Also understanding that depression is sometimes an illness that needs a medical intervention, whether it's a more scripted problem-solving activation therapy, medication management. So I think opportunity within HIV, as you highlighted, to build on the investment that's taken place and to build on this awareness of the importance of the psychosocial environment, to bring in a more focused mental health aspect to address the disorders better.
Quick follow-up. Do you think that the sort of the institutional framework of testing and counseling for HIV settlement and sort of integration, just because it is definitely potentially in a different direction, or ways that it could be integrated sort of with what you were describing, which is a
I think it's an opportunity. I don't think it's independent. I mean, health systems are so, but I think that I think that's a real opportunity because you have a cadre of individuals who are, that's just psychosocial needs in general, and they're already having many related conversations with parents, with patients. So I think there's an opportunity to, to include components that would be more targeted specifically at a depressive disorder if it's present, an anxiety disorder if it's present. One of the multitudes that are already on the menu from which the psychosocial counselors select.
Let me take a few more, just a couple, okay, one more round, so the three of you, and then we'll close after that. The lady here.
I am not a master. Screening, was it active screening or passive? If it's screening, how you how my second question is, what about what do you describe it? Just when there is some people like other than the like they have ADD and then they finance weight. What about the project of suicidality? Like same community and everyone knows each other. So how like get involved in side talk like that. And my last part is about the referral system. Is there like high cases of not oppression, other cases of mental health? What do you do for referral?
My name is Papa, and I'm coming from Suicidality. So I'm interested to know what do you think about the role of community support system or accompanying system in the role that social implement at the community level. Whether your experience or what we have Malawi system is from the system, but particularly we have a network of non-clinical who are really intermediate, kind of accompaniment to patients, and we realize that they have really play in the approval adherence.
Last question.
Interested in health.
These are all thinking of follow-up.
Right.
And sometimes for different reasons, patients do necessarily have constant follow-up. It may be their symptoms worsen, or maybe they have a challenge. I'm trying to imagine that Malawi somehow health centers are from well also one of the conditions. I know the HIV, one more is not I know the HIV treatment has also to the retention percentage and also some of the barriers. But I would like to know when you look at HIV plus mental health.
Great. All right. Thank you. Thanks for these questions. So, first question raised was about active versus passive screening. This is a really key point. So it's active screening. So the difference is, are we just asking providers to direct to us the patients whom they think are depressed, or are we doing our own kind of independent assessment? And the evidence shows that if you do your own screening, you'll identify a lot more patients who need help. They only rely on the providers to direct your attention to those patients whom they think are depressed. A lot of depression goes clinically unrecognized. Patients aren't going to breathe during a visit to their HIV provider unless specifically asked about it. So active screening is really key, and so this is active screening. So that universal screening with the PHQ that I talked about, that's the active screening component. Every patient completes that. So that we do assessments of who might need services, and we kind of step it down through the stages, identify the patients who are appropriate for outreach. And that's about privacy questions or privacy concerns. So were you asking about possible breaches of confidentiality between the patient and the provider whom they might live with, or patients who?
So the provider is confidential, and you can see the privacy.
That is something that we discussed within the context of the way care is routinely delivered. So the HIV testing and counseling itself happens in a private location, and that's where the PHQ2 happens. The PHQ is integrated into the patient's appointment with the clinical officer or nurse, which happens privately, but doesn't always in these very busy, very high volume settings with a lot of time pressure, time demand. So it is I think for mental health, it kind of goes with this question of, are we building a system or are we developing the existing system, right? So do we build our own set of mental health counseling rooms where we can ensure one-on-one confidentiality, or we need to figure out how to make it work within the way that existing care is delivered? And there certainly are challenges with patient volume. I think that's true in many places. Topic of discussion, but it's also topic of discussion with the leadership of the clinics and the themselves about the most appropriate way to handle that. These referrals also, and so there are 3 specialty psychiatric hospitals in Malawi, largely staffed by psychiatric nurses. We had a suicidality triage system. Anyone who endorsed the PHQ-9 item, and based on that, there's a clinical response that was possible. This is all the standard clinical response, safety concern that might have been identified. That could have been much like an ambulance for immediate transport to the psychiatric unit of the hospital that was the nearest hospital. That we haven't had to do that yet. Most that's identified is passive, meaning the differentiation point is that you had thoughts you might be better off in, or do you have a specific plan, intent, identified a means, how much active thought. So that's kind of the first differentiation point that goes into the safety assessment and the appropriate community health workers, and so all those trials that I put up at one point, the large majority of those have focused on training community health workers. So as the people, as a cadre to deliver these interventions, they've all been very successful. For us, we focus on this cadre called the surveillance assistants. Malawi they're lay workers, but they're clinic-based, not community-based. So they have round responsibilities in a village. They are sort of support staff, not really support staff, but they're a support cadre in the clinics, and they do a range of things, including counseling. They help with college campaigns, vaccination campaigns, different things. So since ours is more clinic focused, that's where we focus our training, but there is also a community health worker, like a village health worker cadre in Malawi that would also be an appropriate intervention point that actually has been the focus of some prior studies. I think that there's agreement that those individuals can be effective with a basic mental health first aid package, basic screening, initial support, linking into other services, and with more intense training can deliver counseling with fidelity. And the question that was raised was about loss to follow-up, and loss to follow-up certainly is a big issue. For the mental health study, is our primary outcome, right? So we're interested in whether providing the depression care reduces follow-up to HIV care. So we're measuring it, outcome, but we certainly might be concerned that those lost might be different from those who are retained. And so we would look at that at baseline. Were they the most depressed, or have the fewest social supports, or other things? Certainly is a problem to chronic depression management if patients don't come back. You don't doing, and that real transition point that the HIV field has really tried to make is make clinics responsible for knowing where their patients are. And so again, what are there lessons we can take from that to other chronic diseases, including mental health, other follow-up?
Well, thank you very much. I'm sure Brian will be able to stay out. You can follow with Brian outside, but I'd like to thank you very much. You really generated an enormous amount of conversation and discussion this afternoon.